issues in India. We have a lot of oral cancers, and we have to manage them by day-to-day in our day-to-day practice. So basically, advanced oral cancers are T3 and T4 advanced oral cancers, and they can present with N0, N1, 2 or N3 nodes in the neck. And these N3 nodes can be operable nodes, maybe inoperable nodes. So we go ahead with clinical examinations, of course the biopsies and all other things, but with that we have special imagings, and this imaging includes CT scan, MRI, not only that but PET-CT and PET-MR. Now these are the things which will tell us what status, clinical status the patient is in, and based on that we'll be planning our treatment modalities. Basically T3, T4 oral cancers are treated by surgery, so some kind of neck dissection is always warranted, and it all depends on your clinical examination and imaging whether the patient is in N0, 1, 2, 3, whether he is operable or not. So depending on that we'll take our operative decisions. We operate about 200 patients in a month, and most of them are oral cancers. So, and we are 2 senior head and neck surgeons in our team, and then we have 4 or 5 other people and the fellows. We analyze and keep track of our patients, and then based on those retrospective analysis we come to a conclusion that what should be the best way to manage. Of course there are clinical guidelines and say like NCCN and HACC and all other literature and data support. Based on that we can have, but the most important thing at our place is multidisciplinary team. So we have medical oncologists, radiation oncologists, surgical oncologists, pathologists, radiologists, and jointly we decide the line of management for that patient. See, in India the commonest cancer is oral cancer in male. If we consider the entire epidemiology, it's because of the tobacco chewing and betel nut and areca nut. So these are the risk factors in our country which causes oral cancer, and it is not the smoke tobacco, it's the chewing tobacco which causes oral cancer, and that's very rampant in our country. So that's the reason we get a lot of patients now compared to Western American and European counterpart of oral cancer. They get more tongue and floor mouth cancers, but in my country the major chunk of our oral cancer patients are buccal mucosa and buccoalveolar sulcus cancers. So that's the major difference between the group of patients coming to us compared to Western part. Oral cancer is the best model for prevention because why it is produced. Most of the time it is because of tobacco. Oral cavity can be examined very easily. Examination of oral cavity in a mirror is inexpensive. So the patient who is chewing tobacco can just examine his mouth, and there are definite precancerous lesions like leukoplakias and erythroplakias. So if you teach the community that these are the risk lesions which can convert into cancer, and if they can come in time after seeing an oral cavity having leukoplakias or erythroplakias, you can prevent these cancers, or else at least you can detect them early. The problem is awareness. There are NGOs which are trying hard. There are healthcare systems and healthcare organizations which are trying hard. Government is supporting, but not to an extent which the healthcare workers would expect them to. Say like chewing tobacco can be banned, but because of the political reasons, it's not being done there. The best preventable cancer in the world is oral cancer, and it can be easily prevented if you have good awareness and if you can convince the population in a right way, and more so convince the policymakers.